Today we are talking about 3D CT volumetry of variant gastric reservoir after sleeve gastrostomy and its relation to clinical outcome. First of all, obesity is a global epidemic with increasing prevalence and severity and is linked to numerous chronic illness, higher mortality rates, and is the sixth most important risk factor for diseases worldwide. In 2016, 39% of adults age 18 and over were overweighted, and 36% of adult population in Egypt is obese. Surgery is the only treatment for reducing the body mass index, improving the quality of life, and preventing the weight regain in the obese patients. Its aim to achieve long-term weight loss, comorbidity amelioration, and weight gain avoidance. Techniques are very based on residual gastric volume and their potential relationship between residual gastric volume and weight gain. Gastric capacity can increase late after sleeve gastrostomy, requiring objective measurements of residual gastric volume to determine the late clinical results and retreatment strategy. Recent CT 3D techniques allow for precise reservoir dimensions and correlation with the clinical outcome. Radiology play an important role in gastric bariatric surgery, evaluating gastric reductions. What's our aim of this technique? The main objective of this technique was to assess the ability of 3D CT volumetry of variant gastric reservoir after sleeve gastrostomy and its relation to clinical outcome. Patients and methods. The inclusion criteria exclude all the patients underwent sleeve gastrostomy and psychologically stable patients. The exclusion criteria, pregnant female due to radiations, patients under gastric reduction surgery other than sleeve gastrostomy, and the endocrinal causes of obesity. Patient and methods. The patient first would to do CT on the abdomen with oral contrast. Post-processing of the volume axial CT image, it then was reformatted in the workstation without the need for further patient stay in the CT machine. Then, the axial and the coronal reformatted image were reconstructed at 5 mm slice thickness at CT console. The 3D volumetry rendering image and surface staged display image were reconstructed using advanced workstations. The stomach of the volume was measured in the axial image set after we had traced by the hands with contour of the entire stomach. We calculate the whole stomach then. After that, we apply all the manually traced cuts to the volume calculation software on the workstation to calculate the volume in the cubic centimeters. The gastric volume from the cardia to pylorus was estimated after multiplanar reconstruction and the 3D CT rendering. The patient body weight has correlated with the patient gastric volume. Our examples, case number 1, 35 years old male patient underwent sleeve gastrostomy. Picture A show a pre-contrast image. Picture B show an axial image with the contrast, oral contrast, and its step line. And the picture C show a 3D stomach with its volume. And this operation with normal course. Case number 2, 47 years old male patient with preoperative weight with about 1,080 underwent sleeve gastrostomy with normal post-operative course and weight loss. Post-operative weight after 5 months was about 95. Picture A showed pre-contrast axial cut CT image with its subline. Picture B show our oral contrast axial CT cut, and C show a 3D reconstructed image with the volume of the stomach. And it was a normal course of operation also. Case number 3, 39 years old female patient with preoperative weight with about 110 kilo underwent sleeve gastrostomy with post-operative normal course and weight loss. Post-operative weight was about 96 kilogram. Picture A show a pre-contrast axial CT. Picture B, the oral contrast axial cut CT showing the stomach, and the 3D reconstructed image with its volume, the last picture. Case number 4, it's about 30 years old female patient with preoperative weight is about 100 kilogram, underwent sleeve gastrostomy with a weight loss, and it was a normal course. Picture A show pre-contrast axial cut CT stomach with its stap line. Picture B post-contrast axial CT cuts with its stap line, and the picture 3 3D reconstruction image. This case was post-operative weights show weights gain. Gastric volume was about 132. Picture A show pre-contrast axial cut CT image with its stap line. Picture B show oral contrast CT with its stap line, and picture C 3D construction image show dilated stomach more than pre-operative volume. Our summary: computed tomography plays significant role being comprehensive imaging tool sensitive to accurate diagnosis of any suspected complication. Also, 3D CT volumetry add more value in evaluation of a new gastric pouch volume. Multi-slice CT volumetric study of the stomach is the gold standard imaging technique for evaluation of a gastric size in a post-operative state in a bariatric sleeve gastric surgery. Thank you.
Thank you, Dr. Dina. Any questions?
Thank you, Dr. Dina, for this presentation. But I have a couple of questions. The first one about the oral contrast in the scan. You use it for exclusion of leakage of the, and in the pre-contrast scan, you use effervescent for the dilatation of the stomach, right?
The pre-contrast scan for ensuring that was a sleeve gastrostomy, يعني not other than other operations. The scan is made just to know the volume. The volume, right, of the stomach? Yes, the volume of the stomach. So we are going to give the effervescent just to make a dilatation for the stomach, like CO2 or carbon particles. You give them, and it makes like dilatation of the stomach. Tamam. And you assess the volume, right? Then you give the oral contrast. Or you give the double contrast and make the scan. يعني like that بالضبط. You do both. Okay. There is one complication which is noted, and it's not. It's a late complication of acute abdomen. Did you face something like that? In my study, yes. No. No patients with acute abdomen? About 30% of patients complicating of weight gain. Okay, weight gain, we assess it with the volume. Volume. Okay. Leakage or pain in the first 7 days, we assess for the leakage. But in 14 days, there is something like thrombosis in superior mesenteric artery. Not in my study. Okay, thank you. Thank you. Thank you.
It's my pleasure to welcome Dr. Ibrahim Shalabi, who will give a lecture about how to create a great radiological report. Dr. Ibrahim? Dr. Ibrahim? I think he is late. We should move to the next lecture. Can anyone ask Dr. Ibrahim for the stage? هو اسمه ايه؟ كرام؟ كرام ايه؟ لا كرام خليل. كرام خليل. Okay, we could postpone the lecture of Dr. Ibrahim, and we will have now Dr. Kuram Khalig from Pakistan introducing us